Okay. Good morning. Good morning to one and all. So, what about others?
I need to contact them.
Why always somebody is absent? Yesterday also the same thing.
Not sure, miss.
Maybe I will send a message once again. I think you all know that the attendance percentage is very important. Okay. Please be regular on classes. Okay. Okay, so in the last class, we have talked about this fracture, introduction to fracture and dislocation, right? So we have seen so many things like types of fracture, and then what is dislocation, joint dislocation, and then stages of fracture healing, and then the important principles, that is reduction, what is reduction, and what is immobilization, and what is rehabilitation. So in the first first two stages, our role is not that important, but it is there. Okay, but in the rehabilitation stage, our role is the only thing that is needed for the patient, right? So in the reduction stage, we cannot do much about it. In the immobilization, you can just check. Assessment plays a major role, and then unaffected side, you need to mobilize and strengthen the unaffected side, because there is an unaffected side as well as if, for example, upper limb fracture means your lower limb should also be concentrated. Sometimes because of the overall health and the fitness may be reduced, and you can create awareness and the healthy food, nutrition, this kind of things. And then you can regularly check about the that capillary, is there any obstruction, that is tight POPs, or sometimes infections. If it is a surgical correction, you may have infections and leaking of any fluids or suture removal, this kind of things, and we need to check. And you can alert the um, team. Okay, so that is there. But the only thing, the main role comes in the rehabilitation stage. So nowadays, I told you, right? The earlier on, long back, we believe that we don't use our limb. That throughout the immobilization period, we don't allow the patient to bear weight or do any active movements and all. But recently there is so many articles suggest that we need to mobilize, or we need to start early. In some fractures, we need to start early, as well as in some cases, we need to bear weight. That is, the minimal weight bearing is also required in some kinds of fractures. Okay, but it varies. Sometimes very weak pathological fractures, pathological bone as well as pathological fractures, we cannot do that. We need to delay that. But some situations, you have to start early. So in that case, your functional bracings are very, very useful. So it allows the movement of the joints, as well as it reduces the unnecessary stress also to the fracture side. Okay, thereby we are, that's why yesterday I use it or lost it. That is the major thing. So if you're immobilize it for very long time, means you may other structures, you may have problem with other structures also. They get restricted, or it loses their capacity or level. Okay, for example, sports people, you talk about a sports person and all, it's very crucial that the period of immobilization should be reduced. Otherwise, their returning to the sports activity is really a burdensome for them, as well as for a person who is treating him. So these are the various deciding factors which play a major role in choosing which method is which method is the correct choice. So we have, I already told you, there are huge varieties in these things. Mainly in the shaft fractures, that is humerus shaft fracture, or tibia, femur, this kind of long bones, right? In that things, the type of nailings are very useful. This is plates and screws. So when we need to do internal fixation, nowadays there is no rule, nothing. The surgeons can prefer internal fixations, but there are some indications. So any other method, if there is failure of all the methods, then only they prefer it. But nowadays it's not the situation. So the first thing is, the fracture cannot be managed. Maybe we cannot be sure, right? Money, or maybe some kind of whatever factors they consider it. But nowadays the surgical fixations are very common. You may have come across this, but what we already indications, criteria for internal fixation is, it cannot be controlled by any other options. Then only we can go for internal fixations. And the complex, or many the fracture at many sites, maybe the road traffic accidents, because it is a high impacted injuries, it can occur at various levels. Maybe hip fracture, and then the tibial bone fracture, like that. 2 or 3 places means we have no other option. The surgery is the best one. And one more thing is, and other associated injuries like vascular things, like the bleeding, or the any vessel cuts, arterial cuts, dissections may be there. In that case, to protect the life, we need to do surgery. So along with that, you can do the surgical fixation of the fracture also. And then one more thing is, sometimes it cannot be reduced. Like I yesterday told you, in the spiral fracture, if it is, it's very difficult to reduce it. Like whatever manipulation you have, like maneuvers are there, you need to traction, you need to give traction, and then apply some kind of internal rotation, external, whatever it is. Some fractures cannot be settled down by closed reduction. Okay, so it is maybe displaced so far, means you cannot get it to the point of alignment, right? So in that case also, if there is a chance that you need to correct it by open reduction, then no other way. And soft tissue injuries, so excessive muscle injury or other capsules, ligaments, and this structures also gets affected, means you need to correct it. Maybe tendon ruptures, 2 or 3 tendon, that is the rotator cuff tear is there, you need to correct it by surgery. So one advantages of this surgical methods. So always remember that the open reduction and internal fixation means this is a surgical procedure, and we are going to place any equipments, that is plates, screws, anything, then we call it ORIF. Okay, so what are the advantages means, like x-rays cannot give you a clear picture, or it doesn't give you that, so what we can prefer is, this kind of surgical methods will give you a detailed inspection of that area, and then you can, like it's a clear cut, or the finishing is excellent in this. We cannot have like a non-union, malunion, very rare, and some kind of um, infection. Sometimes infections would be there, but the recovery period is also, is we can judge it. So these are the advantages, and that's what yearly mobilization. We can start the mobilizing process so yearly. That's why, and the perfect finishing. That's what perfect good reduction. Otherwise, taking X-rays and we get a judgment that is not that accurate, and then we are correcting it and then confirming it with the next X-ray. Okay, after completing the reduction, we are going to take next radiograph, and in that case also it is not confirmed. It's not that clear enough, right? So that's why this kind of ORIF or excellent compared to our close reduction and conservative management. And disadvantages, so we all know the surgery has, there is a specific complications and problems after surgery, right? So it causes additional trauma and exposure to microorganisms. So infections can go entry into that. That's why they reduce the period of hospitals stay. Okay, because we can have like after many injury or after any surgery, if your long stay can cause nosocomial infection. That is, in the hospital itself there are so many pathogens that may get into their body that we don't want. So always nowadays there is a specific theme that how yearly back we can discharge them, that much safe the patient is. Okay, and nowadays it's a crucial period that COVID and this kind of things, they reduce the timing of hospital stays and all. And one more thing is, what they are doing is, closed fracture is converted into open fracture. That is also other problem. Okay, so internal fixations and the external fixation that I told you, Elizara ring and this kind of things act as actually, it is one of the devices that will be restrict the movements, right? That is the main use of all the fixations. But what is there means, is there any displacements? Is there any unscrewing? Sometimes it happens anywhere, the mistakes, the human errors are possible. So sometimes unscrewing or some kind of loosening of plates can occur, but we only the pain would be there. Okay, so that is also the one the problem with that. So one more thing is they have some misconception that the internal fixations are strong enough that the patient can manage or carrying weight and everything. It is not that. So internal fixation is a type of immobilization device. Okay, it has some certain pros and cons. We need to obey that. It is not that if you fix it, you can mobilize it or you can weight bear as much as possible. It is not that. Each and every internal fixations and the type of bone it is applied can vary the rehabilitation process. Okay. So that's why the surgery itself has some complications. And so one more thing is you need to do resurgery also, like after a complete union. Sometimes in the elderly people, they left it just we have the fixations with them, but it should be removed. Otherwise they may be reinfected. There is a chance for reinfection, or the screws may cause irritating effect on them. Right, so there are so many old age people comes to me with because of that loosening, or the screws maybe get irritating. Sometimes it happens. So many people comes like in that elderly age, that is the maybe 5 years they left that screw within their body, and then nowadays the surgery is critical or dangerous for them, like they are more like 80 plus and all. So removing the screw also difficult, and they need to survive, or they need to tolerate this kind of problems, because the surgery is a big no for them. So it should be removed. Again, the other one more surgery is needed, or sometimes they left it means that is also other problem. So these are the disadvantages of surgery. And here I told you intramedullary nailing. Okay. So all the shaft fractures, you can use it. So all throughout that medullary canal, we can insert it. And in the proximal and distal ends, we can fix it with screws. So one more thing is either it's a preference of the surgeons that they make use only screws on the distal aspect, or in the proximal or distal, anywhere. Sometimes it's a fixed one. For stable fractures means they have screws in any one aspect, proximal or distal. So here, this intramedullary nailing and all, the trauma is minimized, and then we can decrease the hospital's stay. So this is safe compared to this plates and all. Intramedullary nailing is more rapid mobilization we can do, and risk of complications are also very minimal. Okay. This is external fixations, pins or wires, and you can see the external fixators. The open wounds, in the open wound only we can like excessive soft tissue damages. If there is any muscle injury, in that case, you can use this external fixators. So it's a wrist fracture. The comminuted means it's divided, or it is divided into multiple segments. So in that case, you need to use this external fixators. So in the unstable pelvic fracture, we can use this. And in that, one of the advanced techniques, or in the external fixators, we have Elizaro method. So it is like in the 1940s only, like during World War II, right? That time, because of numerous injuries and fractures, they use this method. Like the soft tissue injuries are very high. So they discovered this type of things in that period. So what is the advantage means, the wires or pins are connected through circular rings. Okay, so non-union cases, if it is a severe, like 6 months, after 6 months also, if fracture is not healing properly or not healed, means we can go for this method. It's excellent for non-union or severe soft tissue damages or shortening. If there is a greater possibility of for limb shortening, maybe bone loss is high, means like some areas the bone segment may become like more powdered. In that way we are losing that, right? We are losing that bone. So sometimes it may cause bone shortening. Okay, so that can also be corrected by this method. So that's why I told you that distraction osteogenesis. The process involved is, in the Elizaro method, we have distraction osteogenesis. Distraction means they are like it can widen up according to the according to the healing process. We can distract it. We can distract the length of that Elizaro rings. Okay, so thereby we can create, or we can trigger the limb lengthening. Okay, so it can correct the skeletal defects also, or deformities. If it's there, any deformities also can be corrected. So it has a multiple use. So the defects, the skeletal defects can be corrected, and then limb shortening can be corrected, and then the deformities, any other valgus, varus deformities also is corrected in this method. So advantages, I already in so many things told you, right? Minimal disruption to the fracture site. So here they won't do like they are not dealing with that fracture site. They are going for the proximal and distal ends. So here you can see that. So the fracture is occurring here, but they are using it on the proximal and distal sides, right? So in that way, we are not disturbing the healing, because sometimes if you're inserting a screws or a plates in the exact fracture site, means it may disturb the blood supply. Okay, so we are not disturbing the fracture site. We are going for little far from that fracture area. And one more thing is, you can directly see the wound and fracture. Okay, so what is the healing process, how the wounds are progressing, and the fracture is also whether it's tender or whether is there any abnormalities, everything can be visible. And then we can adjust it also. After that, I told you, we need to do distractions. We need to enlarge the uh, we can distract the ring, right? So in that case, it is adjusted little bit in the outside itself. We can release the screws, and then maybe under anesthesia, they can feel they can tolerate the pain, and at that time they can extend the length of the ring also. So it is not that big thing, like opening the wound and doing all the corrections. In this way, we can do it without any surgical complications, and used for limb lengthening. And it's like the wound is also not that big, right? That surgical sutures are not there. Only pins they are inserting it. So when you remove it also, it may looks like a small dotted scars. It won't be that uh, big issue. Okay, so they are just pinning it, right? So in the different points, they are inserting the pins. And one more thing is, so we need, only thing important is we are preserving the tissues also. If you're covering it, if you're applying the POP or internal fixation, so it is not possible. Okay, in internal fix, you cannot have adequate bone density or bone properties. So that's why in course you can preserve the tissues also. It can heal parallelly. And disadvantages, and it is open, right? All the pin sites, or there is a greater chance for infection. If you are having a proper hygiene and wound care, there is not a big issue. But sometimes some cases that like comorbidities, diabetes, hypertension, in those people infections are possible, and healing also takes longer time. And that's why I told you we need to have the proper wound care for that whole 3 months or 4 months. They need to give the adequate hygiene for preventing the wound to be infected. And sometimes it looks cosmetically ugly. They looks like some kind of robots, and that appearance it gives. Okay, so that is the other thing. And then the functional impairment. So other soft tissues, the normal tissues are getting pierced. And so other complications are the anesthetic risk. So frequently, if you're for distracting purpose, if you're applying anesthesia, there is an increased chance for that anesthetic complications. And one more thing, for throughout that 3 months or 2.5 months, the patient needs to be in hospital. So the callus formation is also, in some cases, it is not that good trigger for callus formation. And heavy also, carrying it and regularly, it looks heavy, as well as for patients also, they find it heavy only. Okay, other method is traction. So nowadays we are not using the traction. Long back, maybe the traditional methods and Hippocrates, in that stage and few decades back also, we have stressed and give more importance to traction. But nowadays we won't give that, because the impacted fractures or some kind of hip fractures need to be given week time of traction. Okay, that is like application of pulling force. So it's either direct or indirect traction we can apply. So nowadays it's not that common, because what is the main reason means, it may be like the bone in this type of fractures, that is, this is one segment and other segment is impacted. One end is impacted with the other end. In that case, like maybe any dashboard injury fracture, I told you, right? So maybe because of that heavy forces, one segment is getting goes deep into other segment. In that case, what we are doing is we are putting traction to that thing. Okay, so we are distracting for few days, and then we are it is useful for reducing the impacted fractures. Oh, 1 minute, 1 minute. Okay, so, and one more thing is correct limb length also. If there is impacted fractures, we can, it already leads to shortening, right? Here we are giving traction, we are maintain the correct limb length, and we are overcoming the muscle spasm also. Okay, so that in that way, we are reducing the limb shortening. Okay, so this is what I told you. We have either skin traction and another one is skeletal traction. So this one is actually, so this is actually a skeletal traction. Okay, so here they are giving a in the shaft of femur fracture, they give a kind of traction to that segment. Okay, so that's why I told you there are two types of tractions you can give. One is skin traction, other one is skeletal one. So, this one, skeletal tractions, the tape or any adhesive bandages or placed around the limb, whichever we need to pull it, that can be, that should apply a tape or elastic bandage, and weight is suspended. Like traction, we have like equipment for low back aches. In that way, it is designed. Other one is the sliding skin traction. In this thing, we need to go deep into that. So that is two types of traction we have. So this is fixed traction. Okay. So next one is sliding traction. So you can see the alignment of the patient, which tilted on the head end. Okay. So in that way, the body weight act as a one traction force, and the pulling forces occurs on the other side. So if you are carrying, if you hang any weight on this aspect, then it gives more traction. Okay, we can reduce the timing of traction. Maybe for this thing, he needs to be in traction for 2 days. But here in this type of things, you can go for, you can reduce the timing of traction. But one more thing, it should balance, or it should equal the force the patient creates. Otherwise, it may cause some other side effects also. Like too much of force is there means it will produce long gap or a wider gap to that area, that may lead to non-union also. Okay, so we need to be, the timing is also crucial, and the weight you are going to hang also needs to be, we need to judge these two things. So, and one more thing is, if it is like children's, mostly very young age, and they are not that fit for surgeries, you can go for these types of tractions. So gallo, in that case, we can give the gallo tractions. Gallo, this is a widely used one for children's. So you can, I will show you what is that. Yes, this one. This is called gallows traction. Okay, so under 3 years, this type of immobilizations are very useful. So the both legs are, then only if you see the picture, then you get the idea. So both legs are lifted, okay, lifted by, and you can roll or bind up some kind of materials, gases and that kind of thing. So always the main thing is the lifting the buttocks off the bed, okay, and then you are applying traction to the femur. So it's like very common in the supracondylar fracture of lower limb as well as upper limb. In these two things, the muscle forces are so severe that one aspect, like the big muscles of the shoulder, may pulls it towards the fracture side. Thereby, the traction is very important. And the same, the gallows traction is used for lower limb supracondylar fracture, and in the upper limb also you need to have only thing that need traction is this fractures, supracondylar fractures, both upper limb and lower limb. And these are very common in children's also. And then we have like gallows traction, we have Dunlop's traction. Okay, that is the previously we have seen, right? This one, abducted 90 degree, and then you're giving a traction. So here it is a skeletal traction, and here it is skin traction. So skin traction means it's like superficial. Just we are attaching adhesive tapes and everything. But skeletal traction means you are inserting pins or needles to secure that traction effect. Okay, but it is little painful. The skeletal traction is you need to insert a rod or nails. Okay, this is also for supracondylar fracture, and the gallows traction is also for lower limb supracondylar fracture. So for only in this cases, we are using it. Long back, for all types of fractures, they use traction. Traction as a reduction technique. Okay, they used it and they believed it. But nowadays, the situation is different. So is there any femoral or tibial shaft fractures? They use the skeletal traction. That is, that's why I told you it's inserted. That nails or pins should be inserted into the bone. Okay, so, and one more thing, the tongs we have in the cervical type or the cervical spine fractures also, they use that kind of tractions. I will show you once again. Yes. Here, can you see that? So here
Yes.
they, can you see?
Can you?
Okay, so here for immobilizing the cervical fractures, because if you mobilize or in the cervical region, any fracture occurs, and if you mobilize it, means what happened? It may impinge the spinal cord. There is a greater chance for spinal cord compression, and then the whole body is paralyzed. That much of risk is there. So what they do is they insert a pins on both ends of their skull, and then they fixate like this. These are all for stabilizing, and but it's little painful technique. So long back we don't have much option, so they used it this way. So this kind of things for unstable cervical spine fractures, we use stabilization like using tongs, like the rods are inserted by the sides of the temporal fossa. So in fractures of the cervical spine, that's why I told you 2 screws are inserted into the skull and weights of 1 to 5 kg, like depending on the location of the fracture, we can distract it. And this is for a femur fracture. Okay. So both sides are used for traction, and here the point is the skeletal pin is attached. Okay. And then general points concerning traction. So, and one more advantage is some free joints are mobilized, that is lower limb, and whichever is outside the traction force can be moved, and the free muscles are to be contracted. Okay, the other muscles are contracted, but in the POP cases and all, it's like the whole covered area, whichever side the POP is covered, it's under pressure and we cannot contract or we cannot use that area, right? But here other areas are free. And then main disadvantage is patient should be in bed rest. Okay, so he cannot he has to be in that same position, otherwise the traction will change, and it is painful also. So for that, the bed rest, the people with having bed rest, and we need to have good bed mobility, skin care, and respiratory function, because the pressure source and the chest infections and other areas may be get affected. So in that case, we have to give more care on this aspect. Okay, so complications of fracture. Maybe like 90% of fractures we can make the patient to return back as normal as possible, like how he was prior to the fracture, like that you can. But maybe in the 10% of fractures cannot be cannot be secured or cannot have good quality of life. Okay, it varies. It varies from person to person. And so what are the complications means? Some cases it may go for delayed union. It takes longer time than, for example, lower limb 3 months is the normal time period for lower limb healing. But what happen, sometimes it takes longer than that, 4 months, but we can wait for till 6 months. After that also, if you check and it is not it is not healed, means we can then only we consider it as non-union. So till 6 months time period, we can wait for the bones to heal by itself. Okay, so so delayed union is there, and malunion, sometimes wrongly aligned. So it can create some varus or valgus deformities. Like one bonus in this. And if you maybe wrongly you reduce it, or sometimes during the POP there is an immobilization period, because of excessive muscle forces, it may heal done in that way. Either one is happened. So so it may healed in this way. Okay. So it is somewhat of deformity. It is a malunion. Wrongly, it's not in the correct position. So you cannot achieve the normal range of motion. The muscles are also goes for disadvantage. We have various problems with that. And joint stiffness. Sometimes the restricted joint may go for stiffness, and nerve damage. Along with that, any um, nerves may get affected, and yearly arthritis. Maybe after 50 the person is more prone to develop degenerative changes, but if fracture is there, mean it may sometimes the joint stiffness or other because of that immobilization, so many reasons may cause him to have yearly arthritis, yearly problem with that. And then we have avascular necrosis also, the lack of blood supply to that area. These are all various complications of fracture. Okay, so where exactly we are using traction means, like in the supracondylar fractures of the femur as well as humerus, and then in the skeletal, cervical skeletal fractures, we are using traction. Otherwise, it's very rare. We are very rarely use the traction techniques. But long back, we are giving more importance. It's a overrated technique. Now it's outdated. Okay, so this is what is internal. We have come to know what is internal fixation, what is external fixations, what is POP application, what is functional bracing. Okay, what are the advantages, what are the disadvantages for each and every aspect, and then we have talked about the complications of fracture, right? Anything you want to clarify?
No, miss.
Maybe shall we have 10 minutes break? After that, we'll start a new topic. Okay.
Okay, miss.
Okay, so now shall we start?
Yes, miss.
So we have for upper limb fractures. Starts from clavicle and then shoulder joint. Here, that is in the shoulder, we have dislocation. Along with the fracture, we need to see dislocation and then humerus fracture. Okay, so humerus, maybe the proximally head of the humerus and other related things are all considered as the proximal type fractures. And then the shaft and then the distal end, that is supracondylar fractures. That is the three important fractures we have in humerus along with the dislocation, overall 4. And then elbow, in the elbow also we have elbow joint dislocation is there. And then radius and ulna fracture or olecranon fractures. Okay, so we have 3 fractures in the elbow region. And in the distal radius, you have like the carpal bone fractures or the distal radius. Okay, so in this chapter, we are going to see what are the various types of fractures and what are the common methods or management we have. Okay, so you can see the gap, right? This is the clavicle fracture. This is middle third. We have divide the clavicle into proximal 1/3, distal 1/3, and then middle 1/3. Okay, so if most common one is the middle third fractures, and then lateral, either lateral end or distal end, because the clavicle is different in arrangement, right? It is one of the horizontal bones. So we call it either in the sternal end as proximal end or medial end. Okay, so the distal end is otherwise called acromial end or lateral end. Okay, and we all know that the clavicle is the last one to ossify, last one to get mature enough, right? So that is about 22 to 25 years. So you are still not yet ossified. Your clavicle is the last one to harden it. Okay, that is it completes the its maturity. Okay, so the mechanism of the injury for clavicle fractures are like directly fall onto the shoulder. Okay, so just falling sideways, and then great pressure great impact occurs on the lateral end of shoulder, or direct blow, maybe on the clavicle, maybe any weights falling any heavy weights or hitting somewhere else directly to the clavicle. So the main reason is the fall onto the shoulder. Okay, so what I'm saying is, before going into that, I will tell you what are the different mechanisms. Fall onto the shoulder. This one, like this. The impact occurs on the lateral end of the shoulder. This is very common, one of the common types of things, and it may lead to clavicle fracture. Okay, so the fall onto the shoulder. This is other type, fall on the outstretched hand. Okay, so fall on this is very common for upper limb fractures. Majority 90% of upper limb fractures are caused by fall on the outstretched hand. So you are just falling with your hands placed, right? This is the major cause for shoulder fractures. Okay, and one more thing is fall on flexed elbow. Sometimes what happened like this. This is like fall on the flexed elbow. This is also other mechanism of injury that commonly causes fracture. Okay, so either fall on the outstretched hand, or fall on the flexed elbow, or fall onto the shoulder. Okay, these are the various things, and it has various mechanisms also. The muscle forces and everything causes. Maybe if you are falling from a very height places, maybe like you are falling from stairs, like that means it may cause, depending on the speed at which the incident occurs, it will decide the impact and the other involvement of soft tissues also. Sometimes only bony component is getting broken, or sometimes the soft tissues also get ruptured. So here you can, this is also one type, flexed elbow. Sometimes they flexed elbow, but they fall on the outstretched hand. The hand is placed to the floor. Okay, they touch the ground with using their hand, but they may be flexed or sometimes extended. And then so many injuries occurs due to sports also, sports injuries, the contact, we call it contact sports. That is so many things are there, volleyball or football, soccer, and this kind of things. They need to have contact, right? Some kind of, so this may have said they may be like one person may fall on to the other, and like that also so many things are there. So now you can see the different mechanisms, right? So depending on the mechanism of injury, you can decide which type is the which fracture it should be. Very commonly, if it is a low impacted fall on outstretched hand, means maybe the hand, wrist, or radius, till that it may occur. If it is a high impacted or high forced, high speeded injuries, means it may transfer. The weight is the force is transferred, and it is impacted on the proximal end, the shoulder joint fractures. Is it clear? So if it is a low speed and low impacted fractures of fall on outstretched hand, cause fractures in the lower end, that is hand, scaphoid, or wrist fractures, like that. But if it is a high impacted or high speed injuries, may lead to fractures on the proximal aspect. Okay, shoulder joint, clavicle, like that. Okay, so you need to ask the mechanism of injury will tell you what type of fractures it would be. Okay, so we will see whenever we come across, we will see it in detail. Okay, so if you are well versed in that, right, so if you understand the mechanism of injury, we are halfway to the assessment. Easily you can predict that. Okay, so here the fall onto the outstretched hand is very rare here, only 6%. Okay, the main thing is the fall onto the shoulder. So age group in which this clavicle fractures are common is the young age, mostly children's. Common type of the population they undergo is children's, that is under 13 years. So 75 plus comes under 13 years. And group 2, 47 years, below 47 years. And, group 3 is around the elderly group. If a person comes with you, like after the fall onto the shoulder, okay, so what are the things you need to check? right? One more thing is, if somebody is directly hit the clavicle and all, there is a greater chance for in rib fracture also. Sometimes the rib fracture is very, very, sometimes they ignore that, or they won't give much importance to that. So the clavicle is related. The clavicle is combined with your sternum, right? So check the ribs also. Whenever we have clavicle fracture, the patient with clavicle fracture, check for the rib fracture also. Is there any tenderness in the rib area? Because that, if there is any fracture in that, or it may sometimes it looks, some fractures are highly painful and others may it won't be that painful. In that case, the rib fracture is also one of that. It may impinge the pleura also. That may cause some other infections, lung injury or pneumothorax. There is a life, it's a very risky. Okay, we need to deal it the emergency, not clavicle fracture. Only thing that it plays a major importance is you have to give for rib fractures. Okay, so whenever the person comes with a clavicle fracture, check for the chest and rib palpation. Okay, that is very important to avoid the person's death or some other consequences. Okay, so lung injury or rib fracture or pneumothorax, you need to check that. So either you can check the tenderness for the rib fracture, and then only if you palpate, then only they find that there is a pain. Because after immediately after the fracture or after any injury, they always feel numb. Okay, so we have to check for the other symptoms and signs. And then this is very, very important. And then we have to check for any other abnormal movements or abnormality in the clavicle. Is there any projection? Is there any abnormality, any pain in any specific areas? And then check the neurovascular exam. This is also very important, like the capillary fillings. Check the nail bed. Is there adequate pinkish discoloration? After you pinch the nail beds, immediately you see the pinkish coloration. Otherwise, there is a paleness. Sometimes after compressing it, when you leave it, it takes minutes to return to the pinkish coloration. If it is so, then you need to check for, is there any vascular damage or vascular compression? Okay, and then check for the sensation. Is there any lack of sensation in other muscles or palm, dorsal aspect? And then you need to check for the motor examination, muscle movements. But initially, in the after impact, it may work well, but it takes long. Maybe 2 days later, the nerve injury shows its color. Okay, so we need to have thorough neurovascular examination. Okay, this is very important for all types of fracture. You need to check for other because the high impacted injuries are not predictable. Anywhere, anything can happen. For example, hip joint fracture, the femur fractures, sometimes you need to check the pelvis and then the internal organs. That may also get compressed or affected. Maybe the bleeding in the other internal tissues, it's there. So check for other important signs. And then you check for the deformity or abnormal movements. And for all the fractures, we need to check the neurovascular examination. That is 3 things: capillary refilling and any other abnormal sensation, that is pins and needles. Sometimes they feel that some kind of pulsating pain, or this kind of things, or loss of sensation. Sensory examination should be highly recommended. And then what else? That muscle strength, motor examination also should be checked. These are the very important 3 exams for checking any types of fracture. Okay, distal neurovascular exam is very important. That's why I told you, is there any capillary refilling, And then what I told, any abnormal sensations, pins and needles, or numbness, or the pulsating pain. These are all signs of vascular problem. Okay, and then neuro means the loss of sensation, 1 point, and then the loss of motor thing. This is 2. Okay, this is for that. And then these are all clinical examination. Along with that, we need to have some support of evidence, that is radiographic findings. So anteroposterior chest radiographs. Okay, if it is not that clear, means you can go for a clavicular 45-degree or oblique x-rays. Okay, so always I told you type 1. Once again. Okay, this is hiding. Okay. So you have type 1 is 80% in the middle third. Okay, type 2 is distal third, and that is the lateral end. And then type 3 is medial third. Okay, 5%. Okay, so next one is clinical features. Now we are coming to the clinical features. The first thing is the pain, swelling, deformity, inability to raise the shoulder. Maybe they are holding the arm by the side. Okay, always they hold it like that, so slightly elevated. And maybe paralysis, pseudo paralysis. Immediately they feel that there is a loss of motor function. Okay, so here a closed treatment. Closed treatment is without any surgeries. So just a sling immobilization is enough. Because this will heal by itself if it is undisplaced. Okay. And then one more thing is, it doesn't take longer period also. Just 3 to 4 weeks. Not like other types of fractures. Just 3 to 4 weeks with yearly range of motion. Okay, how yearly you can start, that is beneficial, because this is not that weight bearing area. Okay, it's like petala, how it is, like the weight is not transferred through this segment. So you can start the yearly range of motion movements. If it is a displaced one, means you need to go for operative management. So what are the reasons you go for operative things? Means we already know that is there any neurovascular injury. If there is any nerve injury or vessels injury is associated, means you have no other option. Surgical correction is important. And is there any chest injuries? Also you can go for that. And open fractures, maybe one end comes out through skin. And group 2 and type 2 fractures, that is distal end fractures. Why the importance? Means we have one important ligament, coracoclavicular ligament. Is there intact or is it ruptured? If it ruptured, means it will collapse your shoulder joint stability. So in that case you have to go for surgical one. And cosmetic reasons also, sometimes the deformities are due to muscle forces, important muscles, deltoid, pectoralis major, sternocleidomastoid, everything is located here. So if because of unbalanced muscle forces, you can have uncontrolled deformity. Okay, you cannot correct the deformity, means there is no other option, you have to go for surgical fixation. Or sometimes non-union, you are waited for 6 months and still it is it is not healed properly, or it is not healed at all, still the gap is there, means you have no other option, go for surgical fixation. So associated injuries, the brachial plexus, this area is very, very crucial and highly important structures are located here. So the brachial plexus, brachial artery, so many things are there. So we need to check that vascular injury or brachial plexus injury, rib fracture, scapular fractures, and pneumothorax. Either it is it's an extreme only, mild case, that is you can deal with conservative management, or in some cases you have to go for along with the surgical correction, you need to treat the associated injuries also. Either extreme, it is too easy to correct, or struggle to improvise, or struggle to maintain that integrity. So that's what the complications are. We have damage to various plexus, arteries, vessels, lungs, pleura, and late, immediate. These are all immediate. All the eye impacted fractures are associated with any neurovascular structures. We have like at least minimum damage is 50% we can expect some damages in the eye impacted injuries, that is road traffic accident or contact injuries, or like that we can expect. And then in the late complications, late means maybe in the process of immobilization, you can come across thoracic outlet syndrome, malunion, non-union, and then thrombosis of axillary vein, and the supraclavicular nerve involvement. These are all delayed complications, that is you can develop in the process. So goals of treatment. So our treatment, the main thing is orthopedic. The orthopedic surgeon's role is alignment, the reduce it to the proper alignment, proper anatomical position. That is very, very crucial. So intact alignment and stability. So you need to have better stability for that. These are the two important goals of treatment. So otherwise, if you are not providing adequate stability, then you cannot, that the reduction is also useless, and the healing is also not that proper. And then now we are coming to the rehabilitation. So in this thing, the main goal is to achieve the range of movement. We can't we can't compensate on ranges, right? Otherwise, all the ADLs, our ADLs cannot be completed either because of pain or stiffness. So achieve the normal range. And then improving the strength of the muscle, because after immobilization, these muscles are going for weakness, right? This I told you, origin and insertion of this important muscle, sternocleidomastoid, pectoralis, and deltoid. So this is very crucial. And then if you correct both functional range of motion and muscle strength, automatically you improve the functional activities, right? Okay, so the first week, during first week, you can apply a sling or figure of 8 bandages. Okay, so here we cannot apply POPs, right? So for first week, you can apply slings supports. Okay. cuff and collar or figure of 8, anything you can provide. And in the first week also, one more thing is not weight bearing is permitted. Okay, so the weight bearing is not permitted, and no range of and no movements, either neither active nor passive, nothing, no range of movements and no muscle strengthening. Strictly no to all the movements and weight bearing also. Okay, so during that time you have to rely on other normal side. Okay, and after second week, okay, so first 2 weeks this is the protocol, and then the second week onwards you can apply gentle pendular movements. Okay, gentle pendular movements and isometrics to the deltoid. Okay, so gentle, remember that gentle pendular movement and isometric to the deltoid can be started. That is also it's just decided by pain and cooperation of the patient. Okay, so it is if you are starting any new movements and all, it should be performed by patient itself. So you need their cooperation. Okay. Okay, so then we have come to the mobilization phase. So this is the first week no movement, and second week you can start this, and then at the end of fourth week, so you can continue it for third week, the same thing. Gently you improve because the first week, that is second week, you are starting pendular movement, means that time they may be due to fear or pain, they won't cooperate. But later on, you can, in the third week, you can improve the pendular movements and isometrics also. And you can increase the contraction you get. Okay. So mobilization phase. Now at the end of 4 weeks, the gradual mobilization of the shoulder should be started. Okay. So the first week, no movement. Second to third week, pendular and isometrics to the deltoid. And then at the end of fourth week, you can start the gradual mobilization. Okay. Gradual mobilization means it's active is always beneficial. Okay. Don't ever go for passive. Okay. If it is needed or if it is required, in some very rare cases, you can start the passive one. Okay, passive means whatever we are doing, passive stretching, passive mobilizations, I'm talking about that. And by the end of, so you can continue this for 4 to 5 weeks. So gradually you improve the active ranges. And then by the end of 6th week, you can start all the active range of movement to the shoulder is started without any hesitation. So you can achieve it. All the ranges should be like in the off way. And one more thing, abduction, only restriction is abduction should be within 80 degree. Don't go for more than 90. Okay, so this is only one rule that we have for 4 to 6 weeks. In the 4 to 6 week, your abduction, you cannot go for abduction more than 80 degrees. Okay, and then the pendular exercises, same can be continued. All the whatever exercise you continued, you can start, you can follow that also. And the pendular exercise with gravity eliminated. So that's what that is in your standing with stooped position, right? We always start the pendular exercise with gravity eliminated, right? So you need to avoid that. So always you know that, right? The pendular exercises can be yes. So always we choose this kind of way, like pendular exercises. So without any weights also, you can do pendular movements in this stooped position. But here in the after fracture of clavicle, we cannot give it in this way. Okay, so the maybe supine lying, in the supine lying, or avoid this position, the gravity eliminated position you need to choose.
Miss.
Once again, 1722.
Miss.
Yes.
Miss, may I know that when is our midterm exam?
Pardon?
May I know when is our midterm exam?
Midterms are going to be on December. I think December 6th to 10th, I believe. And
I
it's
see.
tentative only. It's not confirmed. So if I get the copy, you get that. Okay. So don't worry.
Okay. I see, I
But
see.
what they said is December 6th to 10th. Okay, maybe it can be changed.
Okay, I see. And Miss, may I ask about the assignment that you give us? Did 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 we need to like do the assignment have any word limit? The words limit, like need to like fill the number of words. Do you have any limit?
It is there. I think you you have in the schedule, in the MSK schedule, right? In that itself you have.
Yeah, I already
Actually,
see the
it is 1,000. It's not 1,000, 2,000. Okay, 20% weightage means you have to prepare it for a word total word counts are 2,000 words. Okay.
2,000 lah.
Hmm.
Okay, because it didn't mention in the
But 10%
yeah.
means you can have 1,000 words. But here it's a 20%, so it's a mistake actually. 2,000 words here.
2,000 words lah. All right, Miss, thank you, Miss.
So just refer this books, the Kistner and the John Ebenezer. This book is really you can get immense information related to different types of fractures. Okay, so here I have so injuries around the shoulder. You can go into this. Very interesting and colorful book. So if you want, you can get other informations like the mechanism of injury. So normally you can write about this things, the fracture of clavicle, mechanism of injury, and then here they said direct direct blow to the site.
Okay, Miss, thank you.
And classification also you have, that is group 1 is middle third, and the pictures are excellent. I think here you can see the methods of conservative treatment. Here either collar and cuff sling, or strapping and sling suspension, or figure of 8 bandage. Okay, so you can use this for all the fractures. You have all the details, all the informations and everything in clear cut way. That's what just use this book.
Miss, we haven't seen the slide, Miss.
Yeah, though now only
Yeah, all right.
So the pendular exercise with gravity eliminated means don't go for stooped position or standing, maybe supine lying. In the supine lying, you can do the pendular exercise without any weight. Don't go for any weights or gravity, just supine lying pendular exercises. In the first week, in the second week also, at the end of second week, you started pendular exercise, right? Here, gentle, after second week, gentle pendular movement, and it also should be done in the gravity eliminated. So I shown you a picture, right? In that thing, it is a gravity assisted movement. Okay, because of that downward movement and weight is there, so it will assist them in for other cases, the PA shoulder or any post-traumatic stiffnesses we can go for. But after fracture, don't choose that position. Supine lying pendular movements can be given. Gentle, whatever is available, ask them to do it. Okay, don't give any passive movements or any assistance, nothing. Okay, whatever the patient can perform, you need to allow that. Okay, so encourage them. You can encourage them to do the movement, but don't touch the patient's limb. Okay, don't give any force. So no weight bearing here also. No weight bearing means don't lift any weights. Maybe anything like starting from any cups or tea. Sometimes they use it. So no weight bearing, strictly no weight bearing. Or sometimes what they do is sometimes they hold whenever they are standing. Old elderly people, they with the help of upper limb support only they stand from the chair to standing, right? That kind of things also you need to clarify them. Don't ever use your upper limb for weight bearing. Okay. And then after that, by the end of 6th to 8th week, okay, so during that time, now only you can start assisted. So you can they cannot achieve it, maybe only 60 degrees of flexion. It's not going more than that. Assistance can be given by the end of 6th to 8th week. Okay, then only you can assist them. Okay, by the end of 6 to 8 weeks, you can have in all the planes no restriction. Okay, all movement, flexion, extension, abduction, internal and external rotation, and then elevation, depression, scapular. So scapular movements they cannot do it, but elevation, depression, protraction, and retraction, all the things in full active and slightly assisted. And then resisted exercise also you can start by the end of 6th to 8th week. That is 1.5 months to 2 months. After that, after 8 to 12 weeks, full active motion, PRE, the progressive resisted exercise, whichever you feel weak, you can start doing the exercises. Like the more importance you need to give it for these 3 muscles: sternocleidomastoid, pectoralis, deltoid. Okay, if it is a post-operative, so if they are corrected with surgical one means, what are the methods means, during first week itself, we can start the gentle shoulder exercise. But in the conservative management, we don't have any movements in the first week, but we can start 1 week earlier if it is a surgical one. And with whatever the unaffected side and left out areas should be given, like the active movement of elbow, wrist, everything should be started. And the second week, they remove the sutures and check the sling also for comfort. Is there any irritation or any wound because of this slings too tight? Sometimes it's too tight means it can cause some kind of friction and wound formation. So that check for that. And then the normal alignment also you can check that, and the dressing, whether the dressing is proper, is there any infection, redness in that suture area should be checked regularly. And then slings can be discarded. So after 4 weeks, there is no need for sling application. So till that level, Whenever they are doing movements, you can remove the sling, and the remaining time you have to make them place in the during sleep also. During sleep time also, they have to wear the sling. Okay, only during active movements. Okay, that time you can remove the sling. Okay. Other than that, the same, the protocol, everything is same. Only things are different, or you are started early. 1 week earlier, you are starting this movements. After that, we have shoulder dislocation. Let's see. I think we will end it here. Okay. Tomorrow 11 to 1, right? We will have class, just a reminder. We will have on 11 to 1. Okay. Let's end it here. Enough. I think we'll start shoulder dislocation tomorrow. Okay, this is a clavicle fracture. So if you want some more information, you can go for John Ebenezer. So what are the complications? That's what malunion, neurovascular injury, everything is little bit elaborated.
Miss,
Yes.
tomorrow not 10 to 11 class.
It's actually 2 hours class, right? I think I told 11 to 1. No, not 11 to 1.
This one's for the replacement class for last week, is it?
Once again, I will check it. So you have class in that time, 11 to 1?
No, miss.
1 minute. Or else, shall we have from 3 to 5? 3 to 5, is it okay?
Which one better for you, miss?
Pardon?
Which one do you prefer?
Because you have only 11 to 1 and 3 to 5, right?
Yes, miss.
Okay, shall we have it on 3 to 5? I have meeting that 11 to 1. 10 minutes meeting only, but if it's okay, means 3 to 5 is convenient for me. What do you say?
When, miss? Sorry, can you repeat again? When do you want to?
Tomorrow.
Hello, miss. Can you hear me?
I couldn't get you, ma. It's breaking. What is that?
Sorry. Yeah. Because my mic, I think, is quite old. Okay. Just ask. 3 to 5 is what day, miss?
Tomorrow 3 to 5.
Tomorrow lah. Can, miss. No problem, miss.
Maybe
Yeah,
you can discuss with yourself and discuss among yourself, and then you can intimate me whether it is 11 to 1 or 3 to 5. But the more convenient thing is 3 to 5 is convenient for me. Otherwise,
Yeah,
you
okay.
have to 15 minutes delay. We can start by 11 to 1. That is also no problem. But only thing is you have to wait for 15 minutes.
I think 3 to 5 better, lah, Miss.
Okay. So let's have tomorrow. I will send you the link for 3 to 5 class. Okay.
Okay, Miss.
Thank you all. Thank you. Let's wind up. Bye.
Alright, thank you, Miss. Bye, Miss.